Welcome to my presentation of EMDR, Eye Movement Desensitization and Reprocessing Therapy for Trauma. Eye movement desensitization and reprocessing, EMDR, is a 32-year-old treatment used in psychotherapy for various disorders and disturbances of the mind, particularly for the alleviation of post-traumatic stress disorder, PTSD, which involves the activation of highly sensitive, triggering, and/or traumatic memories for the purpose of accessing, reprogramming, and re-encoding these memories back into the human storage retrieval system of the brain, such that when they are re-accessed later, they fail to instigate the emotional mechanisms which manifest the upsetting process of PTSD, when negatively impactful life events are recalled in memory. The process of EMDR utilizes Shapiro's adaptive information processing theory to access the brain's traumatic memory network in order to reassociate existing traumatic memories with more positive cues. These cues include some form of external stimuli, such as the tapping of hands, listening to auditory sounds, or the training of specific eye movements for which EMDR is named. Cues serve to rewire memories of past events as present triggers are desensitized and future images of life are formed. EMDR is the founding father of its more updated and revised version, Accelerated Resolution Therapy, ART, the latter of which is a new treatment for PTSD created by a clinician to implement faster, easier healing for those suffering from trauma by utilizing voluntary memory image replacement in conjunction with the external stimulus of eye movements, which help the brain associate these old memories with new schemas of thinking, replacing the original power of traumatic memories and gradually reducing them to brain-stored files of life events. Files lacking the power to control, inhibit, and paralyze the functioning and emotions of struggling clients. Theoretical perspective. Eye movement desensitization and reprocessing, EMDR, an evidence-based, empirically valid, and widely studied psychotherapy used along with cognitive behavioral therapy, CBT, to treat trauma, especially PTSD, was developed by Dr. Francine Shapiro in 1989 from her theory of adaptive information processing, AIP, by which memories stored in the brain can functionally or dysfunctionally impact a person according to the magnitude and direction of their nature. It is the recall or recollection of the memory which holds the individual remembering hostage through pathological phenomena such as post-traumatic stress disorder, PTSD, and other disorders of cognition, behavior, and emotion, such as sleep disturbances, depression disorder, phobias, bipolar disorder, substance abuse, autism spectrum disorder, even debilitating grief in the form of persistent complex bereavement disorder, PCB, and acute mental health emergencies, all of which can be mitigated and assuaged by careful application of EMDR. Of these, EMDR has been clinically approved to treat PTSD, PCBD, anxiety, depression, health issues, pain, body dysmorphic disorder, substance abuse, and bipolar disorder. Shapiro's AIP theory postulates that memory storage networks in the brain, which hold memories of events involving high levels of trauma, stress, pain, abuse, neglect from a person's life, also hold the power to negatively affect the individual as they recall these memories. As memory retrieval for the event occurs, it evokes a plethora of recurrent images from the original circumstance, forcing the subject who is unable to localize the emotional response to the event due to its overwhelming magnitude to relive it, such that fallout from this past trauma produces mental disorders in the present by invading the individual's thoughts, feelings, and actions, such that it detrimentally affects future functioning cognitively, emotionally, and behaviorally. PTSD holds more than painful consequences. It can seriously impair an individual's emotional, cognitive, and social functioning. The resulting disorders can manifest as classic PTSD, but also can include anything from behavioral disorders and sleep disorders to exaggerated grief, depression, anxiety, and fear. But just as the underlying mechanism of AIP can do damage by engendering maladaptive outputs, it can revert to its adaptive purpose with careful accessing and application by a skilled and caring therapist, thus turning the cognitive tool of destruction back into the tool of construction for which it was originally designed. Dr. Shapiro theorized that faulty or disrupted neurological coding, like Freud's free association theory of flawed memory encoding, results in dysfunctional memory storage, and sought to use this theory to alleviate symptoms of PTSD experienced by war veterans without exacerbating their anxiety. Dr. Shapiro's landmark 1989 study confirmed the association between traumatic life events such as war, physical and sexual abuse, or childhood trauma, and disturbing recurrent thoughts, emotions, flashbacks, insomnia, disruptions to life, and dysfunctional behavior. Dr. Shapiro's groundbreaking yet accidental discovery was the connection between saccadic eye movements and the subsequent evaporation of disturbing thoughts after these eye movements occurred. Dr. Shapiro's hypothesis regarding why eye movements are key to the therapeutic effect of EMDR states that alternating bilateral left and right motion of the eyes creates a stimulus effect on the brain, which triggers a connection and hence communication between its left and right hemispheres, such that this communication channel impedes the negative ramifications of physical and psychological fallout from recall of traumatic memories by stimulating the brain to process previously unprocessed memories. The positive effect of this communication between brain hemispheres is augmented by the cognitive load that such eye movements purportedly place on working memory, the short-term memory system we use to temporarily hold information in order to process or control it, to create some output, or to store it to long-term memory. This cognitive overload to working memory inhibits its ability to attend to the impact of recalling unpleasant or traumatic memories, which are incompletely recalled and thereby reconsolidated in a downgraded fashion. Thus, the alternating bilateral stimulation of the eye movement's combined action of increasing dual hemispheric brain communication while decreasing the ability of working memory to further process beyond this concentrated motor functioning task means that these eye movements provide a physical therapy which is both positively restorative and negatively inhibitory. This interhemispheric communication across the corpus callosum, connecting bridge between the left and right hemispheres of the brain, is so powerful as to increase memory function following the left and right horizontal motion of the eyes, which also causes greater communication during REM, rapid eye movement sleep, evidenced by electroencephalographic EEG monitoring. The theory on saccadic eye movements purports that rather than serving as distraction, hypnotic effect, or even classical conditioning to associate the movements with positive stimulation, they actually help the brain create more connections, new associations, which effectively serve to repair any damage done by previous faulty or absent connections associated with traumatic memory. The underlying facilitator of these mechanisms was determined in a 2017 study through brain scans which revealed that patients who had undergone EMDR treatment had more gray matter volume in the left parahippocampal gyrus, a brain region associated with memory, and less gray matter volume in the left thalamic region, an area responsible for sensory processing. Further, because EMDR stimulates excitatory neural firing in the mediodorsal thalamus and basolateral amygdala, it prevents fear-encoding connections from forming. EMDR works clinically at the cognitive and somatic level by reducing blocks in processing and attachments to faultily processed memories. EMDR combines the neurobiological aspects of its mechanisms with prompts from the therapist conducting EMDR, similar to a Gestalt approach, to access old negative memories in the safety and supportive atmosphere of the present moment, and thereby deactivate the pattern of Freud's theory of free associations and reassociate them with new positive and safe affects, which interrupt the destructive pattern of thought processes and reactions and replace them with new ones, while initiating cognitive restructuring that helps manage crippling anxiety and empowers the patient with new connections to previously damaging cognitions. Through EMDR therapy, the client learns to cope with memories, stress, anxiety, and life events through realization of new cognitive insights. Therapeutic procedure. EMDR is a modern form of psychotherapy which incorporates therapeutic procedures conducted by the therapist alongside physical movements performed by the client to treat PTSD. EMDR therapy includes supplementary self-report measures augmenting 8 stages of therapy, which involve the recollection of debilitating memories and verbalization of negative thoughts and feelings to help the client reprocess them by adding positive reinforcement to simultaneous bilateral movements of the body, especially left to right eye movements, but alternatively sometimes the knees, headphones, or hand buzzers, tappers. To begin, patients take the subjective units of disturbance scale, SUD, to rate how negatively they regard themselves from 1 not at all to 10 maximum or worst, and then take the validity of cognition scale, VOC, 1 unbelievable to 7 believable, to rate how positively they regard themselves before therapy begins. Clients repeat SUD after therapy and repeat VOC during and after therapy to measure self-assessment progress on these polar opposite scales. Then the therapy session ensues, cascading through 8 methodical sessions: patient history, preparation, assessment, desensitization, installation, body scan, debriefing and enclosure, and reevaluation. 1. Patient history involves discussion of the target event that initially prompted the client to seek treatment and all of its emotional and life repercussions, and the administration of the questionnaires which identify past causal events, the present symptom-laden circumstances and evaluation of patient coping, and the techniques to transform this dynamic to a state of future well-being. 2. Preparation builds client trust by establishing protocols and teaching the client physical movement techniques and emotional relaxation procedures while letting the client know that they can stop the process at will. 3. Assessment involves accessing at least part of a traumatic memory or its trigger imagery while asking the client how she feels about it and how these feelings are affecting her physically, stress response. Then the client repeats the therapist's true positive statement about the client's established well-being and rates the truth of this positive affirmation using VOC, then rates the negative remark previously stated by the client using SUD. 4. Desensitization involves guiding the client through the bilateral movements while she recalls the target memory and asking her to rate the experience of this memory. Upon reaching 2 neutral or positive emotions associated with this memory, the client takes the SUD again for the target event and any other stressors. 5. Installation involves reaffirming the positive statement affirmed by the therapist as truth. The client repeats the statement, then takes the VOC until she rates statement a 7, totally true, the point at which the client believes the statement is true. 6. Body scan involves assessing the client physiologically for signs of negative impact of prior negative thoughts still affecting the body. Then she is once again asked to recall the target event, at which point the therapist gauges her reaction for signs of stress. Any sign of upset sends the client through the EMDR process again for reprogramming until it is confirmed that she has replaced negative associations with positive beliefs surrounding these recollections. 7. Closure resolves incomplete versus complete target memory sessions. Incomplete entails not reaching a level of positive or neutral belief about the target event, in which case the therapist leads the client through a relaxation session while helping her build coping mechanisms to handle stress outside the clinical setting. Then the test is run again to completion. 8. Reevaluation reassesses the client's emotional, psychological, and physical state by activated stress responses to old memories or new stressors, then guiding the client through the process all over again if necessary to help reach completion. The the point at which the client feels desensitized to the negative impact of the target event and has successfully reevaluated the old fears such that they are new positive beliefs and that the old stressors no longer hold the power to trigger crises. Critical evaluation outcome studies. EMDR holds the distinction as one of the most widely studied current psychotherapeutic procedures. These analyses of its impact on trauma do not disappoint. Despite the preference of the American Psychological Association to rely exclusively on cognitive behavior therapy to treat PTSD, EMDR in conjunction with CBT has become an established and preferred treatment for PTSD by the World Health Organization. EMDR is validated as a cooperative treatment with CBT to address, reframe, and deprogram the mechanisms of PTSD. Balbo et al. Cite that 20 PTSD patients treated with EMDR reduced prefrontal cortex oxyhemoglobin blood levels associated with lower levels of stress. Gaynor et al. Report on the aforementioned 2017 study that revealed that 16 of 19 EMDR patients, when assessed by the clinician-administered PTSD scale, were clear of PTSD. In 2018, a randomized controlled clinical study on female cancer patients revealed unanimous reductions in PTSD, anxiety, and depression. On a larger scale, a 2018 study analyzing 4 randomized controlled trials and 2 meta-analyses of PTSD patients revealed EMDR's cross-cultural effectiveness in dispelling trauma as the swiftest and most effective treatment for PTSD, even beyond the conventional CBT. As evidenced by a 2019 study, 40% of 47 participants with PTSD were qualified as no longer diagnosable for PTSD after a median of 4 sessions of EMDR. Another study of 24 randomized controlled trials confirmed EMDR's positive impact on patients by reducing the negative impact of traumatic memories, and 12 randomized analyses of the eye movement component of EMDR correlated this physical associative motor task and brain retraining tool with reduced levels of negative emotional affect from traumatic experience. As a most powerful argument for EMDR's causal claim of PTSD mitigation, between 1991 and 2013, 26 randomized controlled trials of EMDR as a therapeutic treatment for PTSD demonstrated that EMDR significantly reduced the symptoms of PTSD, anxiety, and depression. Assessing EMDR therapy in the field, EMDR has been shown in review article evaluation to be an effective treatment for PTSD following natural disasters. After a plane crash in Italy, 236 children treated with EMDR felt symptom alleviation. Other studies with positive outcomes included a post-flood study in Mexico and on 1,500 Turkish citizens who survived an earthquake. In the randomized controlled clinical trial of the Gil Jardin et al. Study of 130 emergency room patients with post-concussion-like symptoms, PCLS, who also qualified as having PTSD. PCLS persisted in 65% of the control group, while 37% of the comfort or reassurance group still had PCLS. But of the reassurance group receiving EMDR, only 18% had PCLS 3 months later. And the Proudlock experiment found that most of the 72 subjects in the study required 10 or less EMDR sessions to assuage their PTSD symptoms to stability. A randomized controlled clinical trial of 74 Dutch children with sub-threshold, falling short of diagnostic criteria, PTSD, anxiety, depression, and sleep disturbances following hospitalization for acute illness, who were randomly assigned to either the control group of usual treatment, 37, or the group receiving EMDR, 37, were reassessed after 9.7 weeks of symptoms of each condition, after which the treatment group with EMDR was found to be significantly improved, above the improvement shown in both groups, such that blood injection injury, BII, phobia, depression, and sleep disturbances were substantially reduced, while no significant difference was found between groups in reductions of subthreshold PTSD. Conclusions. Eye movement desensitization and reprocessing therapy holds great promise in treating new avenues of psychological suffering, in addition to the great power it already holds to treat PTSD, both alone and in tandem with established therapies such as CBT. Further research can expand exploratory links between EMDR and the treatment of various types of mental disturbance or mental illness in all groups of people with all types of psychological and/or developmental debilitations under all conditions. EMDR is yielding to accelerated resolution therapy, ART, a more user-friendly version of EMDR with less steps and time involved. So therapists have harnessed and efficiently reduced the process. Whether EMDR or ART works primarily through associative reprocessing or through neurological restructuring or a combination of both, Shapiro's accidental discovery to the fortune and aid of war veterans is an indispensable tool for people suffering with trauma of every range imaginable, and it deserves further exploration to expand the power of its persuasive reprocessing of the traumatized brain. Thank you.